All right, welcome back to the deep dive. Today feels different.
It does.
Usually we're exploring topics for curiosity's sake and maybe looking for some interesting facts or a new way to look at the world.
Yeah.
But today, no. Today we are in the trenches.
We certainly are. The pressure is on.
I want everyone listening to just visualize this for a second. It's 2 in the morning, you're in the library, and there's a huge stack of books next to you. Miller's, O's Intensive Care, Morgan and Mikhail.
And a cold cup of coffee, no doubt.
A very cold cup of coffee.
Yeah.
And you have the Gujarat University MD Anesthesiology exams staring you right in the face. We aren't just chatting today. We're basically simulating an intense, high-yield, survival mode prep session.
That sets the stage perfectly. We are stripping away all the fluff. This is about survival, both for the patients in the scenarios we're going to talk about, and, let's be honest, for the postgraduate student who's facing a very stern examiner.
Exactly. So for today, I'm that stressed out PG student. I've just looked at the syllabus and realized disaster management isn't just a small topic, it's a massive unit. And if I get a 20 marks question on it, I need a perfect structure to get those marks.
And I'll be the senior MD faculty, the examiner who's going to guide you on how to turn all that chaos of information into a coherent, high-scoring answer.
Perfect. So they've got my pen ready. You've got the syllabus, the past papers.
I do, and the topic is disaster management, triage, and the golden hour, but, and this is crucial, with a laser focus on the anesthesiologist's role.
Why is that so important?
Because that is where students lose mark. They write a general, generic answer. You need to write a specialist answer.
Right. Okay. Let's do it. Part A, introduction and exam framing. If I open my exam paper and there it is, a 20-mark question, just disaster management.
Yeah.
I don't got to even start. My first instinct is just to write something like, a disaster is a really bad event with lots of injured people.
And that is exactly how you fail to impress the examiner right out of the gate.
Okay, bad start.
You need a precise textbook definition immediately. Think Miller, think Morgan. A disaster is defined not by the sheer magnitude of the event or how scary it looks on the news.
Okay.
It's defined by one thing, the relationship between needs and resources.
Needs versus resources. Let's unpack that a little.
Precisely. A disaster is an event that explicitly overwhelms the available resources of the healthcare facility or the entire region. It creates a functional disparity between the number of casualties you have and your capacity to treat them.
It's a mismatch.
It's all about the mismatch. Think of it this way. A bus crash with 20 victims. If you're at a big level 1 trauma center with 30 beds and 5 full trauma teams ready to go, is that a disaster?
No, that's just a busy night.
Yeah.
A really busy night.
Right. That's a multiple casualty incident or an MCI. It stresses the system for sure. You might have to call in some extra staff, but it doesn't break the system. You don't stop doing the appendectomy in the next room.
But if that same bus crash happens in a small rural area with, say, a 3-bed clinic,
then it's a disaster. Absolutely. The functional definition relies entirely on that imbalance. And Morgan makes a key distinction here that examiners love to see.
Okay, what's that?
In an MCI, you're stressing the hospital, but normal function doesn't completely stop. In a true disaster, you are so overwhelmed that you must start diverting non-critical patients and, crucially, you stop all elective work.
So the whole standard of care, actually,
Yeah.
it changes.
That is the pivotal concept. You must write that in your introduction.
Yeah.
In a routine emergency, we operate under, deontological ethics, patient-centered care. We do everything we can for every single person.
Right.
In a disaster, we have to shift. We move to population-centered ethics. We switch to utilitarianism.
The greatest good for the greatest number.
Exactly. And that ethical shift is the foundation for everything else we're going to talk about.
I see. So for the exam introduction, define it by the resource-need mismatch, distinguish it from an MCI, and then immediately bring up that ethical shift. Now, why are we, as anesthesiologists, the ones who get this question? Why isn't this just for the ER doctors or the surgeons?
Well, just think about your own skill set. Who is the absolute expert in airway management?
We are.
Who manages circulation, shock, and resuscitation better than anyone else in that acute phase?
The anesthesiologist.
And who is comfortable with extreme pressure, running codes, managing the ICU? It's you. Miller emphasizes that anesthesiologists are the natural leaders in disaster response because we're the complete physicians in that acute setting. We're not siloed.
That's a good way to put it.
You can work in the OR, the ICU, the ER, or even in the parking lot doing pre-hospital triage. You understand the logistics, the critical care, and the sorting all at the same time.
Okay, so that's my opening statement. I've justified my existence.
Correct. And for bonus points, you should briefly mention the legal aspect.
Oh.
You can say that disaster preparedness isn't just a good idea, it's a requirement. Mentioning things like the CMS emergency preparedness, rules, risk assessment, communication plans, policies, training. It shows you've read the administrative sections of the textbook.
So it shows I'm not just a technician. I'm thinking like a department head.
Exactly. It always impresses an examiner.
Got it. Okay, let's move on. Part B. Disaster management itself. If I'm structuring a long answer, I need headings. The outline says, Disaster Management Overview.
Always use headings. It makes the examiner's life so much easier. So, under that heading, you need another definition. Disaster management is the systematic organization of resources and responsibilities for dealing with the humanitarian aspects of emergencies.
It sounds a bit dry.
It is, but it's the framework for everything else. It shows you're thinking systematically.
And the objectives? What am I trying to achieve?
3 main ones. 1, reduce mortality and morbidity, obvious. 2, restore normal function, get the hospital back on its feet.
And 3.
Protect the staff. I cannot stress this one enough. Miller is very clear on CBRN chemical, biological, radiological, nuclear safety. If the anesthesiologist becomes a casualty, the whole system loses a critical asset. You cannot save anyone if you are dead.
Safety first. Self, scene, survivors. In that order.
That's the mantra.
Okay, that brings us to the types of disasters. I know I need to classify these for the exam. Is it enough to just say natural versus man-made?
Yes, that's the main classification. Keep it simple but comprehensive. Natural disasters and man-made disasters. But within those categories, you need high-yield examples that show you understand the specific clinical implications.
Let's do the natural ones first. What are the classic examples I should memorize?
Earthquakes. Classic example. Miller cites Haiti and Fukushima. But don't just list them. You have to mention the specific medical problem. For earthquakes, it's crush injury.
Right, which leads to rhabdomyolysis and acute kidney injury.
Exactly. So as an anesthesiologist, you're not just thinking about setting broken bones. You're thinking about massive fluid resuscitation to prevent renal failure from myoglobinuria. You're thinking about hypokalemia from cell death.
Okay, what's next? Tsunamis.
Miller cites the 2004 Indian Ocean tsunami, the ACE disaster.
Right.
The unique feature there is the incredibly high mortality to injury ratio. Most people drown. The survivors often have aspiration pneumonia or what they call tsunami lung.
Tsunami lung.
It's a horrible polymicrobial pneumonia from inhaling contaminated swamp water. And the other key point is that the infrastructure is usually totally destroyed. The hospitals get washed away.
And the third one, hurricanes or cyclones.
Think about Katrina or Maria. The big issue there isn't just the wind, it's the flooding and, critically, the loss of power and clean water. Miller notes that Hurricane Maria completely devastated the supply chain for IV fluids in Puerto Rico.
So the disaster management there becomes about logistics. How do you run an OR without power, without clean water, without saline bags?
Exactly. You have to be prepared to work in an osteo environment.
Okay, moving to man-made disasters.
You've got your standard trauma, big transport accidents, building collapses, but then you have terrorism.
This changes the game completely.
Because of the secondary device.
Yes, they set off one bomb to draw in the first responders.
And then they set off a second one to kill the medical team.
Correct. So safety of the scene is absolutely paramount, but the really big category you must nail for the exam is CBRN.
Chemical, biological, radiological, nuclear. I feel like this is a favorite Viva topic. Let's break it down.
It is. Okay, for chemical, you need to focus on 2 main types: vesicants, like mustard gas, and nerve agents, like sarin.
Miller talks about the Tokyo subway attack for sarin.
Yes. So what's the anesthesiologist's primary role there? What's the pathophysiology?
Well, they're organophosphates, so they inhibit acetylcholinesterase. You get a massive cholinergic crisis.
Right. And what does that look like clinically? The SLDGE mnemonic: salivation, lacrimation, urination, defecation, GI upset, emesis. But the killer bees are bronchorrhea and bronchospasm.
They drown in their own fluids. So you need to manage the airway, which is incredibly difficult because you're probably in full personal protective equipment, or PPE, and you need the antidote.
Atropine.
And lots of it. Massive doses. This is a key Viva point. You are not giving 0.5 milligrams like you would for a slow heart rate. You're giving 2 to 6 milligrams repeated every 5 minutes until the secretions dry up. You might use hundreds of milligrams on one patient.
Wow. Okay, so atropine until the lungs are dry. Got it. What about biological?
Think anthrax, smallpox, or pandemics like COVID-19. For us, the role shifts to critical care management and rigorous infection control.
And radiological?
You have to distinguish between a dirty bomb, which is just conventional explosives spreading radioactive material, and a full nuclear detonation. But for the hospital, the key principle is decontamination. You cannot bring a contaminated patient into the OR. You have to decontaminate them outside, or you contaminate the entire theater and shut it down for days, making it useless for everyone else.
Okay, I think I have the classification down. Now, the outline mentions the phases of disaster management. This seems absolutely essential for a structured answer.
It is. It's a perfect framework. There are 4 phases. You must memorize them: mitigation, preparedness, response, and recovery.
Mitigation is prevention, right, before it even happens.
Yes, exactly. Building codes to withstand earthquakes. Flood walls, things that prevent the emergency or minimize its effect long before it's even on the horizon.
Then preparedness.
This is the planning phase, before a specific event. This is where Miller and O's talk about drills, disaster exercises. It's about stockpiling resources, creating surge capacity.
Yeah, what exactly is surge capacity?
It's knowing exactly how you'll expand your services, where will the extra beds go, which stable patients will you discharge to make room. It's also having a call-out tree to get staff into the hospital quickly.
And then the disaster hits. That's response.
That's the immediate reaction, the hot phase. Search and rescue, triage, stabilization. This is where we shift into damage control mode.
And finally, recovery.
Returning to normal. And Miller makes a very poignant point here. Recovery can take years. It involves rebuilding infrastructure, of course, but it also involves dealing with the long-term mental health of the providers.
PTSD.
PTSD in medical staff is a significant and often overlooked part of the recovery phase. You have to mention it.
Okay, that covers Part B really well. Now we're moving into the real heart of the matter, Part C, triage. The notes call this exam gold.
It absolutely is. If you get a short note on triage, you must start with the definition. It comes from the French verb trier,
Meaning to sort.
meaning to sort. And what is the goal?
Doing the greatest good for the greatest number. That utilitarian principle again.
You must explicitly state that ethical shift. In normal medicine, if a patient comes in with a devastating brain injury and, say, 90% burns, we throw everything at them. We use the ICU, the ventilator, the blood bank, everything.
But in a disaster.
In a disaster, that one patient consumes resources that could potentially save 5, maybe 10 other salvageable patients. So ethically, in a disaster scenario, treating that unsalvageable patient is actually the wrong thing to do. It wastes precious resources.
That is a really hard pill to swallow.
It's the hardest part of being a triage officer, and anesthesiologists often take on that role because we are so good at rapid assessment of airway, breathing, and circulation.
Yeah.
We can look at a patient and in seconds say, this airway is compromised, or this person is in shock.
Let's classify triage. There are different levels, aren't there?
Yes. 3 main types you should mention: primary, secondary, and tertiary.
Primary's out in the field, pre-hospital.
Right. This is the first sweep at the scene of the incident. You are not treating, you are just tagging. You are sorting people quickly.
And secondary.
That happens at the medical post or at the hospital door. You have to reevaluate everyone. A patient who is tagged as stable might have deteriorated during transport. A patient who looked dead might now have a pulse. Triage is dynamic, not a one-time event.
So you're constantly reassessing.
Constantly. And tertiary triage.
Is that about who gets definitive care?
Exactly. Who goes to surgery first? Who gets the last ICU bed? Morgan notes that in a typical MCI, about 20% of the victims will require urgent surgery. Your job in tertiary triage is to find that 20% and prioritize them.
Okay, now for the really crucial part. The categories. The colors. I need to know this cold.
Absolutely. 4 colors: red, yellow, green, and black.
Red is immediate.
Life-threatening, but treatable. That is the key phrase. But treatable.
Give me some examples.
Attention pneumothorax, airway obstruction, uncontrolled external hemorrhage. These are things where if you intervene right now, they live. If you wait 30 minutes, they die.
Okay, yellow is delayed.
Correct. Serious, but stable for now. A fractured femur, a stable abdominal wound. They definitely need care, but they can probably wait 45 to 60 minutes without an immediate risk of death.
Green is minimal.
The walking wounded, abrasions, minor burns, a sprained ankle.
And Miller mentions a specific problem with the green patients, doesn't he?
He does. Because they can walk, they often bypass EMS and drive themselves straight to the nearest hospital, so they're the first to arrive, and they can clog up the emergency department before the critical red tags even get there by ambulance.
So you need a plan to manage them. to corral them away from the main trauma bay.
You need a separate area for them, absolutely.
And finally, the most difficult one, black, expectant.
This means dead or unsalvageable.
And this is the exam trap, isn't it?
It is the ultimate Viva trap. The examiner will give you a scenario. A 25-year-old male, victim of a bomb blast, open skull fracture, brain matter is exposed, GCS is 3, he has gasping respirations, and his pulse is thready. In a normal trauma scenario, what do you do?
Well, in a normal ATLS scenario, you'd immediately intubate, call neurosurgery, and throw the kitchen sink at him.
But in a disaster triage, Viva,
He gets a black tag.
he gets a black tag. You provide palliative care, maybe some analgesia if there's any sign of consciousness, and you move on to the next patient. You save that ventilator for the red tag with the correctable pneumothorax.
And if I say intubate,
If you say intubate in a disaster, Viva, for an unsalvageable patient, you might fail the entire station. It shows you don't understand the fundamental ethical shift.
that's brutal but crystal clear. Okay, so how do we actually make these decisions in the field? We need a system. The outline mentions START.
START. Simple triage and rapid treatment. It's the gold standard for adults. It's beautiful because it only uses 3 simple parameters. RPM.
Respirations, perfusion, mental status.
Exactly. It's designed to be done in under 60 seconds per patient.
Can we walk through the algorithm? I think that would be really helpful.
Let's do it. You're at the scene. The first thing you do is shout, anyone who can hear me and can walk, get up and move over there.
And all those people are green. The walking wounded.
Correct. You've just triaged a whole group of people in 10 seconds. Now you go to the first victim who didn't get up. Step 1. Check. Breathing. Are they breathing?
Let's say, no.
Okay, they're not breathing. You do a simple airway maneuver, a head tilt, or jaw thrust. If they start breathing after that,
They're red. Immediate. You save them.
you save them. If you open the airway and they still aren't breathing,
They're black. Expectant. You move on.
right. Now, what if you find them and they are breathing spontaneously?
Then you count the rate.
Yes. What's the cutoff?
Over 30.
Over 30 breaths per minute, they are red. They're likely in shock or have hypoxia.
Okay, what if their breathing rate is normal, under 30?
Then you move to perfusion. You check for a radial pulse or capillary refill time if there's no radial pulse or the cap refill is over 2 seconds.
They're red. They're in shock.
Correct. And if perfusion is okay,
Then you check the last one.
yeah,
Mental status.
right. Can they follow a simple command, squeeze my hand? If they can't,
They're red. Altered mental status.
and if they can follow a command.
Then they passed all of RPM. They're breathing normally. They're perfusing. They're conscious. So they are yellow. Delayed.
You've got it. It's a simple, logical flow chart, and you should be prepared to draw it in the exam.
Right. And just briefly, you mentioned SALT and Jumpstart.
Just mention them to show you're up to date. SALT is sort, assess, life-saving interventions, treatment transport, and Jumpstart is the pediatric version of START. It just adjusts the respiratory norms because kids naturally breathe faster. You can't use adult rates for a toddler.
Okay, I think Part C is done. Let's move to Part D. The golden hour. Another exam favorite.
It is a classic concept, but O's intensive care notes that the strict 60-minute rule has evolved a bit. It's really about the concept of rapid definitive care. The urgency is the key.
So what's the physiological basis? Why do we care so much about that initial time window?
We are fighting a battle against the triad of death.
Hypothermia, acidosis, and coagulopathy.
Correct. Once a patient spirals into that triad, it's incredibly hard to get them back. And on a cellular level, we're trying to prevent irreversible shock. We're trying to stop mitochondrial failure. Once that happens, it doesn't matter what you do. The patient is going to die of multi-organ failure days later.
And Morgan talks about the trimodal distribution of death.
Yes.
Where does the golden hour fit in?
Yes. So the first peak of death is immediate seconds to minutes. A lacerated aorta, a brainstem injury. We can't save those people. The third peak is days or weeks later, sepsis, organ failure. The golden hour is all about targeting that second peak, the early deaths.
So the ones who die in the first few hours.
Exactly. The deaths are a tension pneumothorax, a blocked airway, or a major hemorrhage. These are the preventable deaths. This is where we make the difference.
Okay, so what are the priorities during the golden hour? In med school, I learned A, B, C, D, E.
And you need to update that for your exam. The paradigm has shifted significantly. It's now CABC.
The little C stands for catastrophic hemorrhage. That comes first.
Absolutely. O's intensive care is very specific on this. If a patient has an arterial bleed spurting from their leg, you don't waste time looking at their airway. You put on a tourniquet. You control the exsanguinating hemorrhage before you do anything else. You can't intubate a dead body.
Okay, so C is first, then A, airway.
C-spine control is mandatory in trauma, and you intubate if GCS is less than 8, or if there are obvious airway burns, or an expanding hematoma in the neck.
Then B for breathing.
Oxygenation.
Mm-hmm.
And critically, you decompress a tension pneumothorax based on clinical signs. You don't wait for a chest x-ray if the patient is unstable. You use a needle, then a finger thoracostomy.
Can C for circulation.
This is where you get large bore IV access. And here's a huge high yield point. Hemostatic resuscitation. We now prioritize blood products over crystalloids.
We'll get into that more in the anesthesiologist's role, I assume. D for disability.
GCS, check the pupils. A quick neurological assessment.
Get E for exposure.
You expose them to look for injuries, but you must prevent hypothermia. Miller emphasizes warming. Remove wet clothes. Use warm blankets, warm fluids. A cold patient is a bleeding patient. The coagulation cascade is a series of enzymatic reactions, and enzymes don't work when they're cold.
That segues perfectly into Part E, the role of the anesthesiologist. This is the absolute core of the exam question.
This is where you earn your marks, and you need to divide this answer into 2 clear sections. Outside the OR and inside the OR.
Okay, outside the OR, we've already talked about being the triage officer.
Yes, but you're also the resuscitation leader. Anesthesiologists are comfortable with lines, tubes, pressors, and chaos. We often end up running the resuscitation bay, serving as the trauma team leader.
What else?
Transport. We're experts at stabilizing a critical patient to get them safely to the CT scanner or for transfer to a higher-level center. And Miller notes that in a massive pandemic or disaster, anesthesiologists can serve as temporary intensivists.
Right, because we know ventilators inside and out.
Exactly. When the ICU staff is completely overwhelmed, we are the only other specialty that can competently run multiple ventilators and manage complex vasopressor infusions.
Okay, now, inside the OR, it's not just business as usual, right?
Not at all. You might be managing multiple operating rooms at once. You might be supervising non-specialist staff like nurse anesthetists or junior residents who've been pulled in to help. You need to ensure rapid turnover of cases.
Let's talk specifics. Anesthesia in mass casualty situations. Resource limitation is a huge problem.
It is. What if you run out of pipeline oxygen? What if the electricity fails? Miller suggests you need to be prepared to switch to TIVA total intravenous anesthesia or even use old-school draw-over vaporizers if the medical gases fail. You have to be adaptable.
So, ketamine becomes your best friend.
Ketamine is your best friend in a disaster. It supports blood pressure, it provides profound analgesia, and it doesn't rely on a compressed gas source.
What about regional anesthesia?
It's incredibly useful. A good nerve block spares ventilators. If you can do a femoral nerve block for a fractured femur, that patient doesn't need a general anesthetic, they don't need a machine, and they don't need one-on-one recovery nursing for airway monitoring. It frees up staff and resources.
Let's really dig into damage control resuscitation, or DCR. This is a buzzword we need to use.
Absolutely. DCR has 2 main pillars relevant to us. The first is permissive hypotension.
So you're saying we should deliberately keep the blood pressure low?
Yes. O's intensive care suggests a target systolic of 70 to 90 millimole Hg until the surgical bleeding is controlled. The idea is if you push fluids and bring the pressure up to 120, you might pop the clot and restart the hemorrhage.
But there's a big exception, right?
A huge exception. This does not apply to patients with a traumatic brain injury or TBI. They need a higher perfusion pressure to perfuse the brain. But for penetrating trunk trauma, you keep them on the dry side until the surgeon can clamp the bleeding vessel.
And the second pillar of DCR is the transfusion ratio.
Right. Massive transfusion protocols, or MTP. We are moving completely away from giving liters and liters of saline. We want a 1.1.1 ratio. 1 unit of plasma, 1 unit of platelets, for every 1 unit of packed red blood cells. We are trying to reconstitute whole blood.
And why is that so important?
To prevent dilutional coagulopathy. If you just pour in red cells and saline, you're diluting all the patient's own clotting factors and platelets. You fix the oxygen carrying capacity, but you make them bleed more from everywhere else.
There's an ethical component to this section, too.
A huge one. Playing God. Who gets the last ventilator? Who gets the last unit of O-negative blood? As the leader of resuscitation, or the intensivist, anesthesiologists often have to make these impossible calls, and it causes what we now call moral injury.
Right.
Miller suggests we need to be very aware of that for our own mental health and for the health of our teams after the event.
Okay, moving on to Part F, hospital preparedness. This feels like the administrative side of the answer.
It is, but it's high yield for any medical, legal, or administrative short notes. Every single hospital must have a disaster manual, and you should know what's in it.
Surge capacity is a key term here again.
Yes, and you need to be specific. Miller talks about how to expand ICU beds. Can you turn the PCU, the post-anesthesia care unit, into a temporary ICU?
Yes, of course. It has all the monitors, ventilators, and staff.
Exactly. Can you use the ORs themselves as ICU beds after the initial surgical rush? Yes. You have to have a plan for that.
And canceling all elective surgery.
Morgan notes this is the single fastest way to free up specialist staff and beds. It's usually the first step in activating the disaster plan.
What about the blood bank? How do they prepare?
The ICU book by Marino discusses protocols for using low-titer group O whole blood or having an emergency release protocol for O negative, but in a huge disaster, you might run out of O negative.
So what do?
You might have to switch to O positive for males or postmenopausal females. It's not ideal, but it's better than nothing. You need a protocol for that before the disaster hits, not trying to figure it out in the middle of the chaos.
And conserving the blood you do have.
Yes. This is where point-of-care testing comes in. Using a TEG or ROTEM machine. You don't just give products blindly if you have the ability to test what's actually missing. It saves precious resources.
The outline also mentions communication.
Because it is the first thing to fail, cell towers get overloaded instantly. The hospital needs a backup plan. Often, the most reliable backup is low-tech. Runners. People physically running with messages between departments.
Part F also mentions documentation and medico-legal aspects. In the middle of all this chaos, do we still have to document everything?
Yes, but you keep it simple. Triage tags are the key. You attach the tag to the patient. It has their vitals, their color category, what interventions you did, what drugs you gave. You don't have time for a full electronic health record entry for every single patient at first.
And what about liability if I don't give a patient the standard of care because I don't have the resources?
This is where crisis standards of care come in. These are legal frameworks that are activated during a declared disaster. They protect providers from liability when it's impossible to provide the usual standard of care.
So I'm protected.
You are, but, and Miller is very clear on this, you must document why you deviated from the standard. You have to write, ventilator unavailable due to surge, or blood products exhausted. Documentation is your protection.
Okay, finally, Part G, exam integration. Bringing it all home. The outline suggests comparison tables, which are great for written exams.
Absolutely. Draw a simple two-column table. Column A, disaster. Column B, MCI. Row 1, standard of care. For disaster, it's low or altered. For MCI, it's maintained. Row 2, help. For disaster, neighbors also affected. For MCI, help available from neighboring hospitals.
Another good table would be routine triage versus disaster triage.
Perfect. Routine. Cardiac arrest gets treated with ACLS. Disaster. Cardiac arrest gets a black tag and is considered expectant. Routine. Resources go to the sickest first. Disaster. Resources go to those most likely to survive with intervention.
We mentioned the black tag trap already. Are there any other common Viva traps I should watch out for?
Fluid resuscitation. The examiner will try to bait you. They'll describe a trauma patient in shock and ask what you'll do. They want you to say, give 2 liters of crystalloid fast.
But I shouldn't take the bait.
Do not take the bait. The answer is damage control resuscitation, early blood products in a 1.1.1 ratio, and permissive hypotension.
Any other trap?
Your own role. If they ask about the role of the anesthesiologist, don't just say, I give anesthesia. That's an instant fail. You are a leader, a triage officer, an intensivist, a resuscitation expert, and a logistician.
Okay. Diagrams. If I have 5 minutes left in the exam, what should I draw?
3 things. 1, the START algorithm flowchart. Walking, breathing, circulation, mental status. 2, the disaster cycle as a circle. Mitigation, preparedness, response, recovery. And 3, a simple triage tag with the tear-off color-coded strips.
Okay, let's wrap this all up. Let's create a summary or a model conclusion for the exam paper.
All right, here is your closing paragraph. It's strong, it's concise, and it uses keywords. In conclusion, effective disaster management hinges on the 4 Ps: preparation, planning, practice, and performance. The anesthesiologist, with their unique skill set in physiology, pharmacology, and resuscitation, is the natural leader in the chaotic environment of a mass casualty event, bridging the critical gap between the field and definitive care.
That is perfect. I feel about 1,000 times more prepared now.
You have the definitions, the classifications, the triage protocols, and the clinical pearls. Now you just need to get it down on paper, legibly.
To all our listeners out there who are preparing for the Gujarat University MD exams or any other board exams, good luck. You know this stuff. Just structure your answer, use the keywords, and think like a consultant.
Go get that MD.
See you next time on The Deep Dive.